Hi, welcome back to Hidden Parts the podcast. My name is Sean Monet, and today our topic is health related. I know that some of us, if not all of us, know someone or are related to someone that has been diagnosed with diabetes or sugar. Our guest today, Erica Hall, a board certified nurse practitioner and certified diabetes care specialist, is here to dispel the stigma associated with diabetes. Welcome to Hidden Parts the podcast, Erica.
Hi, thanks for having me.
I'm so happy to have you here. You have a multitude of experience that you want to share with us, including your resource center.
Yes, I do. So again, I'm Erica Hall. I'm a nurse practitioner and a certified diabetes care and education specialist. I have a clinic in Northern Parkway, Hall Diabetes. That's Hall, Hall. I'm from the South, so it may have a little drawl. So it's Hall Diabetes Management and Resource Center, located on Northern Parkway in Baltimore. And that's where I'm located. And it's all things diabetes.
That's wonderful, and it's so needed, particularly in our community. You can correct me if I'm wrong, but diabetes affects the African American community a little more harsh than other communities. Do you care to enlighten me?
Yes, let me say, over 37 million people in the United States have diabetes. Of that percentage, at least more than 9% of people don't even realize they have diabetes. So it's undiagnosed. And there's 19 million people who have prediabetes. So that's in general of the population, but in the African American community, when we look at the percentages of diabetes and the diagnosis and undiagnosed diabetes, we are second in line after Native American population, which you may note are on reservations, have higher prevalence of diabetes, but we are not far behind them. It's not just the diagnosis of the diabetes that concerns me within the African American community, it's the outcomes. So the complications of diabetes are prevalent. We can talk a little bit more about them. But with those complications, if we're found more in our population, our outcomes are worse with those complications. It could be resources, could be an issue, access to care, I would say access to good care, competent care, culturally relevant care has been, I've found in my years of experience, can be an issue and one of the barriers that leads to some of these complications.
Wow. So your experience, you spent about 10 years at Johns Hopkins University working in this line of work.
Right.
And did that propel you to getting your own clinic because of
what I saw in the Hopkins? Well, I was at Hopkins 20 years. I did my grad studies at Hopkins, and I was always passionate about diabetes because being from the South, originally from North Carolina, I had family members who died from the complications of diabetes. And even at a young age, I would see and wonder where was the advocate for these people in areas where there was no resources or they died from complications that could have been controlled, given that diabetes, and I tell my patients this all the time, greater than 90% of diabetes management is self-management. So my goal is always to empower them to know that they're able and they're capable of managing diabetes and not just throwing in the towel.
Right. Okay. Behavioral changes.
Behavior changes are key. So to digress, I worked in diabetes, so the endocrine division at Johns Hopkins for 10 years. I did research in all areas of diabetes, including post-pancreatectomy diabetes, and I've taught in Trinidad and Tobago. I've done a lot because at Hopkins is a research, institution as well, and so I was able to be a part of a lot of very cutting edge research and understanding diabetes on all different levels. However, at the end of the day, I still saw our people, our population, when I would see them with such significant complications. And some of the barriers that were there, although we have this big Hopkins here in Maryland and then the University of Maryland as well, and you're right in the middle of an area where there's basically a pandemic of diabetes. And so why are the outcomes still the way they are? That was my question always. And so I knew from before starting undergraduate, I was actually a credit analyst before I went back to school for nursing. That was my background, and God spoke directly to me. And because I was so passionate about diabetes, because I saw family members pass away, He indicated you will go back to school, and it was clearly stated you will go straight through, because at that point I'm an adult, I'm not right out of high school. You will finish school, you get educated, and I said, oh, gotta go to Hopkins, supposed to be the number one. I'm in North Carolina at this point, so let me go to the best, because I want to be the best if I'm gonna do it. And you're going to complete that, and then you're going to open a health clinic for underserved. And if you chase money, I'll just add this in, it was clearly stated if you chase money, you'll fail. And so every single thing that was stated in that, when I felt that presence and pushed to move, all those things have come to pass. I will say I stayed at Hopkins, and I did get a tremendous amount of accolades, a tremendous amount of opportunity, but I knew what my purpose was, and that's what God made it clear for me to do it.
That is so important.
So that was it. So we're walking in that purpose, and I stepped out on faith when I opened Hall Diabetes during the pandemic. With not, how God said you might not see where you're going, but you step because you go walking out on faith, and that's exactly what I did. My husband decided he was going to, he saw, it takes a mustard seed, because I had been saying I was going to do it. He had that mustard seed, and he said, we're going to roll over this retirement, and we're going to go out, we'll say on a limb, but go out on God's word and start this clinic. And that's what we did.
Wow.
And so in the end of 2018, going into 2019 is when I stepped out, and I finally gave a resignation to Hopkins to leave, not with one patient, not with one, had a plan, of course, and had a location, but not one patient, but with a plan and with a purpose. And I'll constantly trying to get through my purpose to people in our community. So I do, some volunteer work in senior housing, and just want to be present, try to be present as I can. And then I have the clinic part. So I see patients, and I actually go into patients' homes in nursing homes, assisted living homes, where people can be overlooked when it comes to diabetes. I'm working diligently trying to get in with the dialysis centers. If you notice or not, they're building a lot of dialysis centers.
Yeah.
Next to hypertension is diabetes, are the leading causes for patients being on dialysis. Hemodialysis, meaning kidneys have failed, and so now you need a way of cleaning having the cleaning system of the kidney. So it's the artificial kidney. That's what dialysis is. And so we're building so many. It's 2 on Northern Park. It's at North Avenue. It's 2. I just saw one. I was surprised in Towson. And so they're building more dialysis centers. My concern is, what are we doing to prevent this progression within diabetes or high blood pressure, which sort of go hand in hand.
Wow. So let's peel back a little bit.
Sure.
And go back to fundamentals. What is diabetes? So
diabetes, so you may hear people say, I have a touch of diabetes. Let me go from pre-diabetes to the diabetes. Okay. So there's a commercial now that really bothers me, Ozempic. I shouldn't say the company, but it's a commercial on TV, and the lady is singing and dancing saying, I got a touch of diabetes. But, and for me as a provider for diabetes, you cannot use that terminology by saying a touch of diabetes, because you don't think it's as severe or important. It's like a person, I just got pre-diabetes. I don't have diabetes. I'm not on insulin. I don't have this. I have pre-diabetes. The fact is that pre-diabetes, meaning your blood glucose level or blood sugar level, they're high, but not high enough for a diagnosis of diabetes. Okay, so just to be clear, we're not getting too technical. So sugar, meaning carbohydrates, dextrose. You may hear those words used interchangeably. That's a primary energy source in the body. In pre-diabetes or in the progression to diabetes, your body is still, in type 2 diabetes, your body is still making insulin, but it's resistant to it, the insulin. So if your cells, which need the energy to get into, every cell of our body needs the energy, in order for the glucose, which is the energy, to get into the cell, it needs insulin. So think of insulin as the key to open the cell to let the glucose get in.
Okay.
And so in type 2 diabetes or even in prediabetes, there is resistance. So the key is there, but it's not working as well. Just keeping it in very simple terms.
Okay.
It's just not able to work as well. So you really got to put more pressure to push it. So what happens in prediabetes, the pancreas, which is the only organ in the body that makes insulin, our key, is that it is churning out more insulin in order to combat the resistance. So in prediabetes, you don't have the symptoms. Your blood sugars are still normal or near normal, but not. It's like below. It's like 90, below 100. Okay, so anything bumps up above the 99, then it's like, okay, with prediabetes. Above 126 is could be diabetes, but it has to be a second test to confirm it. And so we're trying to look at those numbers. And so in prediabetes, the pancreas is working overtime, releasing insulin over time to bring the blood sugars to normal. So when your doctors check you every year, your glucose level fasting is normal, they say, okay, boom, that's it. For us, if we know you're at risk, we may look at other tests. If I look at a person, look at an insulin level, the insulin levels are really high. That means the body is releasing a whole lot of insulin in order to keep the blood sugars normal. That's prediabetes. Type 2 diabetes, same difference. It's just the resistance is there. But by this time, the pancreas is burnt out, right? And so it's burned out to the point that it can't combat the resistance. So now the blood sugars are too high. And then you're diagnosed with type 2 diabetes. So in type 2, you're still making some insulin. Your body just can't use the insulin properly.
Okay,
So,
and type 1?
In type 1, your body doesn't make any insulin. It's an autoimmune disease. It's idiopathic. So it's not really a way of knowing how did I get this type 1 diabetes. It is something that we would say used to be childhood diabetes. So you would see it in children and now normally. But I still have patients who are much older who have a diagnosis of type 1 diabetes. We look at antibodies, do blood testing, and I sort of can tease out because the presentation of a patient with type 1 diabetes is normally a thinner person because it's not the fact that some of the resistant causes of the insulin resistance could be, we'll talk about for type 2 diabetes, but the person that's a different look normally, but not all the time. And so you don't want to say, oh, that person's thin, they don't have type 2 diabetes, they could. This person is thin, they may have type 1 diabetes, they could, but it could be either one. But there's antibodies that we look at to can tell us that this person has this autoimmune condition and it's type 1 diabetes. That would mean they'll be on insulin for life unless they have a transplant.
Wow. Okay, so I know each person is different, and you would examine them on a case-by-case basis.
Right.
So I'm going to ask you a general question. You find out that you have pre-diabetes. What's the first thing that somebody could make a behavioral change, a pivot in their lifestyle, if you will?
So the pre-diabetes, so if you are sedentary, if you're not wanting to get up and exercise or moving your body at all, start moving. Okay, I'm not telling you to run a marathon. I'm not telling you that you have to be on the treadmill for hours. What I'm saying is our studies have shown completely that at least 30 minutes a day of some cardiovascular exercise, that means getting up and walking, getting your heart racing. If you have a treadmill, then get on that treadmill. If 30 minutes at one time is too much for you, let's split 15 minutes twice a day. Look at the commercials in between your TV. Do something to move your body and get your heart rate up for at least 30 minutes a day. This is a starting point. If you are overweight, you want to try to lose at least 7% of your body weight. So changing it, it's all behavior changes. What we found is that with behavior changes, they sometimes are hard to maintain. So it doesn't take, it can take you a week or so to make it a habit of doing something. But behavior change sometimes can be difficult for people to maintain. And so that's when, even in prediabetes, medication can be started. But before we even get to medicine, lifestyle changes are going to be prevalent in any level of diabetes. Pre-diabetes, diabetes with severe complications. You have to make lifestyle changes.
Okay, so moving past pre-diabetes, you have diabetes. type 2.
Okay.
Most of your patients are type 2.
So yeah, so the prevalence of diabetes, so the percentage is more than 70%, 80% of all diabetes is type 2 diabetes. So
Okay.
yes.
So what determines whether you're insulin dependent or just plain medication?
So
Pills, because all of it's
yeah, so
medication.
I understand. So really, if you're not managed with oral agents, or if there's a contraindication for you, if you are unable to take certain medications because you have side effects to it, or you already have conditions that make it impossible for you to take those medications safely, then you'll move to insulin. I feel that if you start insulin early enough, I don't put people just to put them on insulin, that you can reserve some of the islets, which are the cells that make insulin, because they're not having to work as hard. But besides that, it's if you're on different agents, because there's different classes of medications that can be used to help slow any progression to complications or from prediabetes to diabetes, that are available, that are pills or non-insulin injectable medications. I'm sure you've heard of Ozempic before.
Yeah, and now they're calling it the weight loss drug.
Yes.
Yeah.
And then you have the complications. And so many, the unfortunate part is, it's not that it doesn't lead to losing weight, which it does. And so a lot of people are getting on it. And then you may see all these different clinics pop up saying, we have the weight loss medicine, come and get it. It's not really the brand name. They get a mix of different things they put together, and they put it, and then you wonder about why you have these. Why do I have gastroparesis, which is one of the risks for this medication? Why I'll have these side effects? Because they're not really looking into those like you should. I'm a firm believer, I'm going to prescribe you any medication, we're going to look and make sure your risk, we're going to consider your risk, we're going to consider the risk and benefit for you.
That's actually a benefit, because when you, and it's nothing personal about the bigger outfits, but when you come to your center, it seems like it's more of a one-on-one, personable approach to your health and lifestyle.
That's exactly right.
And that time that you spend with someone would include, this is the medication that I recommend for you. This is the side effect.
Oh, yeah.
And you kind of walk them through that. So you give them a choice, so to speak.
That's right.
And I think that's very important, don't you?
Yeah, my motto is we take the time to care, because in the hospitals and things, you're going to always have, at the bottom line, you want to get patients in, you want to get them out so you can get another patient in and get them out. I understand the concept. But for me, I want to make sure people understand, and I am a firm believer, I want people empowered to know that they can do it. It's not this, and I want them to be honest with me. So I want them to feel comfortable, to be able to be honest, because I'm going to meet you where you are. Okay, I don't expect you to have all the answers. I don't expect you to be eating cardboard, because that's where patients come in. The first thing, what am I supposed to eat? I can't eat. I don't want to just eat cardboard. I don't know what to do. I live in this kind of neighborhood, and so you think about these disparities, the food deserts, the safety mechanisms. You go to providers. I've heard them, working with providers say, well, you need to walk every day. Go out and get some vitamin D. But if I got a blue light on my corner, if you're from Baltimore, you understand, and you know the safety in doing so, how easy it for you to say it. And then when you come in, you vilify them because they haven't done it, but you haven't realized why they haven't done it. What's the goal there? So you never change anything, and then a year go by, and then now we see complications. I want to avoid that. But if complications present themselves, I want to know that we can work right there. What can we do? What are we doing? In some cases, we can do everything right. Diabetes is a progressive disease. So you can do everything right in some cases and still end up with complications.
So on that same note, you can do everything right, but because of genetics, you could still wind up with it, or is that not true?
So no, so genetically you can, so like first degree relatives increase your risk for developing diabetes by 50%. Gestational diabetes, again, same thing, about 40 to 50% increase of development of diabetes in your lifetime. Because of those things, we cannot choose our genes. I always say that you can't choose our genes, even though in America,
just the ones you
put on, get your little stretch in them. But otherwise, you can't choose the genes. Your parents are your parents, and your family is your family. I know they're trying to make humans out of goats or everything else at this point in this country, in other countries, but really you don't choose your genes. And so those risk factors are there. But I always tell people, just because grandma had it, auntie had it, and I know as soon as they got it, the doctors gave them insulin, then all of a sudden the foot fell off. You hear all those things. I've heard it all. And I say, just because it's in the family doesn't mean you have to take that, right? So you do do the lifestyle stuff in advance of the risk. Diabetes risk increase as we get older. So as you know, if you decide that you're just not going to be moving and grooving and doing anything and eating whatever you want and drinking whatever you want and living whatever you want, and you have a risk factor, will you luck out or not get it? Possibly, but the possibility of you getting it is very high.
Wow. So it's holiday time.
Yes, it is.
And we're going to be throwing down for Thanksgiving,
Oh, yeah.
Christmas dinner, and the whole 9 yards.
Yes, indeed.
Do you have anything to offer in terms of choosing your diet wisely?
One thing I wanted to do is I like to remove the stigma for diabetes. So if you have a family member who has diabetes, not to vilify them in the midst of the holiday. Let them enjoy the holiday. But what I always tell my patients, you're not going to eat the whole sweet potato pie. You're not going to eat, and going into the holiday, if you eating cake and pie every day, then leading into Thanksgiving, and then you're doing that, then you're putting yourself up of having, your blood sugars being high and you're not feeling well. And the thing is, the high blood sugars over time that leads to complications. So if you make a decision, and I'll probably have some of my dietitians say, well, you should tell them just to add artificial sugar, sweeteners, and that's a whole different show. But what I would say is you have to eat in moderation, and then after you eat, get up and move. So walk while the turkey's in the oven, do a walk. Eat the food the family enjoy, and then get up and move. Play a game that's dancing the game. Move. It's still with the family. You're not separated from everyone else, feeling like, well, I have to eat cauliflower rice while everybody else. I have to eat cauliflower rice while everybody else eating everything else, all the good stuff. I can't eat all the yams. Well, you have to be mindful, and you can change. Get some spices to season things, and a lot of times we think about just the sugar, so the sweet potato pies and the cakes but you have to think about also your cardiovascular health, because the number one killer of patients with diabetes is heart disease. So you want to be able to protect your heart while you're doing that. So let's try some turkey in your greens, or even just some seasoning in the greens, and not the ham hock. I'm from North Carolina, so I know what go in there. I know the fat back and the ham hock. I know what is normally put in there, but I do know that it clogs your arteries. And I do know with diabetes, it can stiffen your arteries. So if you're clogging stiff arteries, you're going to get a blockage, you're going to have a heart attack, and can kill you. Okay?
So is that the same with butter?
Yeah, butter. Anything that's solid at room temperature.
Fat?
Yes. So trying to limit the saturated fat. And so, you have our month for heart disease. We talk about heart disease, but interchangeably you think about heart disease and diabetes. So for me in managing diabetes is the ABC, your A1C, which tells me where you are. The B is blood pressure, and the C is cholesterol. All those have to be managed. So if you're seeing me, I'm not just saying, okay, we're talking about diabetes, because diabetes encompasses every part of your body, mind, spirit, all of that. So we talk about the importance of give me a moment here. The importance
of healthy living.
No, yeah, not just healthy living, but also for the mind and body. So the importance of meditation, the importance of decreasing your stress. And holidays can be stressful for people. Holidays can lead to depressions for people as well. All of those things will affect your blood sugar. Because
the diagnosis of diabetes can lead to depression.
It does.
And it could revert. You could just say, I am not eating anything, which will cause a whole other set of health complications.
Because not eating anything is not going to take away the diabetes. That's the thing. It's not going to change that. If you have the diabetes, it's there. Not eating anything is not going to change the fact that it's there. Will it prevent your blood sugar from going high if you're not eating anything high in carbohydrate? Yes, but the diabetes is there.
So if you have diabetes, you do have to eat more frequently, though.
So it's not that. So what you want to do is eat, and this is people with diabetes without. I would recommend small meals, like what you call. I would tell my patients, like you have a breakfast and a snack, lunch, snack, dinner. So and I say a snack for lack of a better word, because when people think snack, they think in chips, they think in snacks. But no, you're having something balanced, could be like between 20 to 30 grams of carbohydrates. And we won't get into the gist of that in between. So having a moderate sized breakfast and then a small snack in between, a few hours in between, so that you're never hungry. You're never starving. And that's what you want to do, because say you go all day, I'm not eating anything. It's not like you're on an intermittent fast or anything. I'm not going to eat anything. Get home. What's going to happen? You're going to be reaching for everything that's moving and eating it and just throwing it back. And then the blood sugars are spiked. And then you go to sleep, they're high. So you wake up in the morning, they're still high. And it's going to be hard for them not to be high throughout the day, because you have insulin resistance if you have type 2 diabetes. So that those being able to have small meals throughout the day, then you're not feeling deprived and you're eating something. And I always say balance it out. Don't just sit and eat the grapes, okay? Because grapes are, you get nutrients from the grapes, but there's sugar. Grapes are just sugar. So if you're going to have the grapes, how about some cheese or some cottage cheese, something with some protein, healthy fat in it? That one prevents the spike in the blood sugar. Because what happens if you just eat the grapes by themselves, the blood sugars will spike. So it's just like simple sugars would do that.
So Erica, we talked about diet. I want to get a little more specific.
Okay.
For a couple of reasons. And I'm guilty of it. Whenever I go out with my loved ones, particularly those that have diabetes, one eyeball is always on the plate, and I am guilty for saying, should you have that? So hearing you talk about vilifying the illness is big. It really is big, and I'm repenting right now for my behavior. I could see how that would be really, it's stigmatizing.
It is.
And you're setting that person apart, bringing all this attention to them. So outside of not doing that, what is a healthy portion that one would expect to have with diabetes?
So I always say this, because before the mindset was there's a diabetic diet and a person with diabetes follows these rules, but I'm more in the mindset of everyone should be doing portion control when they're eating. In having diabetes, you will know that carbohydrate is the nutrient that causes a spike in the blood sugar. So when they're balancing their meals, everybody also can do it, because it leads to extra weight, these carbohydrates, but all carbohydrates aren't created equal. So I'll give you an example. So the plate method, maybe some of your listeners may have seen the plate method, maybe their doctor's office or something. It's a plate, and half the plate is vegetables, and then you cut the plate in half. It's like those old cafeteria plates, and then you put your starches in one little area, and then your meat or your protein. I say meat as a protein, but it's in the area. When we think about ounces of protein, like a piece of roast beef or a piece of chicken breast, you think about almost like a deck of cards, or like in the palm of your hand as a size for meat, for your protein. On the side of your veggies, we're thinking about the non-starchy vegetables, right? So not your half a plate of corn or half a plate of sweet peas. I don't know if anybody wants either one of those. But like if you have green beans or even your collards or even a salad on that part of your plate. And then your starches, if you want the potatoes, if you have a small amount of, macaroni. And I know people say, okay, here she goes with a small amount of macaroni. It's coming to holidays. What are we going to do? So like I said, you having that, so you got to combat that. So when you go out to eat, for example, if you get the plate with the foods, cutting that amount in half. Let them box up the first half, and you eat that half, and you still are enjoying the food within the interaction with your family. You're not feeling like, oh wow, I'm not being able to enjoy my food. And you have the meal and not as much. And so you're not eating to get overstuffed, period. But just balancing is going to be the key.
And eating to live as opposed to living to eat.
Eating to live and living to eat. And that's a great saying, but it's so hard.
It is very hard.
It is a mindset change, and it is possible to do. And it's helpful when people aren't, looking at you and vilifying you, because as soon as you vilify a person at the table, they say, okay, I ain't going to eat. They're going to get home, it's going to be like this.
And they're going to overdo it. Yep. Yeah.
Like
so I'm gonna, just for the GED section, I need to walk something back. Can you give me some, because carbohydrates play a big role in this.
Oh yeah,
can you break it down? Like give me a few examples of some carbohydrates.
Okay, so I know most people think carbohydrates, the first thing they think diabetes, they think is just sugar. And when they think sugar, they're thinking processed food like cake and donuts And rice, people always think about rice and potato and bread, right? Those are carbohydrates. But you have to also know that every fruit is a carbohydrate. All fruits have different glycemic index, meaning how fast they're going to cause the blood sugar to spike. Some cause it to spike faster than others. So when you're looking at a fruit tray, so I want to have fruit in the morning, but I like to have in my fruit tray, I want to have grapes and I want to have bananas sliced up, and that's what I want to eat. That don't really match, but somebody might have that. Or I'm going to eat a banana in the morning. Those are two fruits that both have a high glycemic index, which causes the blood sugar to go up really quickly. So let me do berries. So strawberries, blackberries, blueberries, raspberries, those berries have a lower glycemic index. They're still carbohydrates, but they're not going to spike the blood sugar like you're going to get in the grapes and the bananas. Okay. All fruits are carbohydrates. So just to break that down. Now, someone say, well, I eat bread. I'll eat the wheat bread. At the end of the day, white bread and wheat bread are both bread. At the end of the day, they're both sugar. They're all carbohydrates. Now, the difference is a white bread, a regular soda, are simple sugars. That means you eat that white bread, it's going to spike your blood sugar really quickly, what we want to avoid. You have a really actual wheat bread, multigrain bread, you have the fiber in it. So fiber is part of that calculation of your carbohydrate. So you're not going to have the spike in the blood sugar. So it's going to give you the nutrients without spiking the blood sugar. So that's why when you say, let me choose the wheat bread over the white bread, small changes you can make.
Okay.
And so people say, I just can't stand wheat bread, but you need to take one slice of white bread. So remove the white as you can. That's what I'll say.
Okay. Well, this brings up another topic, and oftentimes, particularly with seniors, the budget is minimum.
Right.
And you have to make choices when you go to the market. And processed foods, for whatever reason, seems to be more affordable sometimes than a more healthier option. So if you find yourself in that situation, I mean, money's tight for all of us. So where would you suggest people pinch from?
Okay.
You know, instead of like maybe processed cheese, what would you suggest?
So one thing I always tell patients, because I've had patients who say, well, I have canned beans, I have this, I have, this is what I can afford. So I always stop them and I say, well, let's look. If ShopRite has a sale, they have senior day on the days. Find those days when things are cheaper. But believe me, frozen vegetables are just as good as fresh vegetables because they're normally frozen fresh. And you can find cheaper, get the store brand ones. A lot of times people say, I want my name brand ones. The store brand ones, they're probably in the same building where they're making these fruits and vegetables, these vegetables that they are frozen. You can get them at a lower cost and more than a can, because once you open the can, you sort of eat that for that day or maybe 2 days in one can. If you got a bag of frozen vegetables, you can take out a couple of those and you can just spread that out longer, and it's better than the canned. Same with the fruit. Fruit, you don't want to get a whole bunch because over time, unless you know how to preserve it well, then it will get rotten. But getting when they're on sale and not compromising, saying, well, I might as well get the lunch meat versus let me cook some meat, because you get if within a budget, getting a tray of meat is something you can freeze some pieces and you just sort of cut on those pieces to make them spread out. I try to help patients in the idea of that I know we like it's easier to get some of the processed foods. Let's say that. If you happen to be in a store and all they have is frozen meals, you want to try to get the ones with the least amount of sodium as much as possible. But I always say, if there's a way to get a pack of meat versus getting a frozen meal that's going to last you one day, getting a pack of meat and just break that meat up and make that last for your week. Get you a bag of beans. I know growing up, we had a bag of beans. We actually had to pick the beans and do all that with the beans growing up down in North Carolina. But actually getting those beans and cooking that and let that last. And what's left, freeze it. And then come back to it. Those are ways. If you have, again, I meet people where they are, and knowing there's resources in the community that can also help. And sometimes people just don't know where the resources are.
And as part of your practice, do you have access to those resources to
So
share?
I find out about the resources when there's food giveaways at churches, if there's flu and vaccine clinics. when I have those, I make that people aware of those. Yes, I do.
So I talk about food being costly, but insulin is pretty pricey as well.
So if you have Medicare, Medicaid, insurance will cover it. Insulin can be costly out of pocket, but if you're insured, so that's why I said get on to make sure you get like Medicaid. I know this year they had to reapply. You lose your benefits. Medicare, Medicaid, you have to make sure you reapply or you lose them, but they do cover it. And also Walmart and now I know Walmart for sure. You can get lower cost insulins, like out of pocket. The insulin, nothing's over $20. For patients with Medicare, no insulin is over, and Cigna and a couple of the commercial insurance for our older individuals, no insulin is going to be over $35. That was something that came from the federal government to make insulin more affordable to everyone.
That's awesome.
Mm-hmm.
Very awesome.
It's the newer medications that are very costly. And so we find out all this new data. We understand that how this is working. It's protecting the heart, it's protecting the kidney. So all these great benefits to help prevent complications. But it's $1,500 a month. And insurance will cover it, maybe, maybe not. And so that's where you have the disparities that come into play that we fight for every day. Fight against every day.
Wow. This conversation has been so enlightening.
Very good.
I'm just like ready to make an appointment. I am serious because even without diabetes, everybody could benefit from just lifestyle changes.
That's right.
To prevent either getting it in the long run or just being more healthy.
Just being more
in
healthy.
General.
Yes, and we all can benefit from it. That's why I move away from saying this is a diabetic diet, and I want to change everybody's mindset when they call a person a diabetic. We don't call a person with cancer a canceritic or anything like that.
Oh,
so
that is
again,
real.
You change the wording. You have to change the word for people can feel empowered. So you are a whole person who happens to have diabetes, which can be managed, and you're capable of doing it.
Wow. Like I said, I want to make my appointment now. How would someone find you and make an appointment?
So my website is halldiabetes.com. Very simple. You go on there and you can make an appointment right through there. Otherwise, the phone number is 667-260-2826. You can call and make an appointment.
Okay, and I'll also include that in the description of this episode for anybody that's interested. But do you accept insurance?
Yeah, accept a number of commercial insurance and all Medicare and Medicaid.
Awesome. So what else you got going on?
Well, I am a certified center for diabetes, the CDCES program for diabetes prevention program, which is a 12-month program in which the first 6 months I see people, you will be seen twice a month. Twice a week, and then after the next 6 months, it's twice per month. It's really about education and the lifestyle modifications that are very important in preventing progression from prediabetes to diabetes. It's open to any patient who has prediabetes, have been diagnosed, or think you're at risk for prediabetes or diabetes, and we'll test you right in the office. And I'm coming up on the next cohort of patients, hopefully to start in January, where we start off fresh in January. It'll be a whole 12 months that we'll do these classes right there in the office. Well, it's a office next to my office where we'll sit in, but I'm more hands-on. I like to go. So we'll meet at the grocery store, one of our meetings, and then we'll meet at the track and go walking, one of those meetings. We'll have massage therapists to talk about how the mind and the body go hand in hand. Will be there. I have a chef who will come in and do some cooking, some healthy cooking as well. So my diabetes prevention program is a little bit more encompassing.
Wow. And I know November is National Diabetes Awareness Month, but like a lot of holidays that we celebrate, it deserves more than a month.
It's every day.
It's an everyday choice.
It is. It's an everyday lifestyle. It's every day you have to deal with it. One thing that we do, and like type 1, we don't talk about a lot, but in general of diabetes, when patients are, in particular on insulin, if you think about having a balloon, and this is one of the things that you may see it on social media, it's like a balloon, somebody's bouncing a balloon around and just walking around throughout the day. That's like the highs and lows of diabetes. And so just not knowing when you might go too low, maybe too high when you're on insulin for diabetes, and how that affects your mood and everything. And so if you have a loved one or know someone who happens to have been diagnosed with diabetes, be it type 1 or type 2, having some grace and move the stigma from it.
Mm-hmm.
And not saying, look at him over there with diabetes eating that candy bar. There's a thing called diabetes fatigue, just like any chronic disease, you get fatigued from having to deal with that. Having to deal with like maybe going down a roller coaster, not knowing that you're coming to the hill. We can anticipate like on a roller coaster when it's going, blood sugar's going down, or if your blood sugar's low. Like let me go back. We can anticipate that we're going to get to the hill on a roller coaster. But imagine diabetes never knowing and not being able to anticipate that drop or anticipate what's going to happen. So having some grace towards to those people, to anyone who happens to have diabetes or even prediabetes, with or without complications.
Okay, I know we've been going at it for a minute, and I promise that I'm going to end this soon, but mental health awareness with diabetes and the association with the two.
Yes, so a number of things, because mental health, you have to think about, just like I just indicated, diabetes fatigue, there's a correlation because you have a chronic disease and can lead to depression. And some of the medications that treat some mental illnesses, including depression, cause increased insulin resistance. So it makes managing the diabetes a little bit tougher, never impossible. We can always adjust, but also if you have, sometimes there's conditions in which you don't feel like, I don't have diabetes, or you can't, there's some resistance to just managing yourself, not just the diabetes, just yourself in general. So making sure all those assessments are done when I see you, to see if there's something, and I also always will refer to see if, there it's a need for therapy at all. If it's a need for medication, there shouldn't be a stigma on that either. Unfortunately, it can be.
Yeah.
And with us, patients that come in and they feel the stigma. They want to make sure everything is fine. I don't know why I'm here. I have this, but I'm feeling fine, because you think that's what I want to hear. I don't want to hear that. I want to know, because I want you to be empowered to feel good. I always tell patients, you want quality and quantity of life. I had to learn that everybody's idea of what quantity, we all know how long you want to live, but quality of life. What does quality of life mean to you? And I asked them, what's your reason why? That's what I want to know. What is your reason why that you want to live longer? Why is your reason why you want to manage your diabetes? Because you have to know why you want to do it. And it shouldn't be your external locus of control, like someone else because of someone else. What is it about you that you feel like you're valued enough, that you deserve to live long enough, that your purpose that God have you on earth hadn't been met yet, that you still want to be here? So if that is the case, and we've written that down, so we are we agree this is what you want to do. So these are the steps we have to take. Okay, so and diabetes is one of those diseases that you feel good until you don't. Like, I feel fine. I don't need to take nothing. They said I'm fine. I don't have to take anything. But you sort of forgot they prescribed something. You forgot they said move like 30 minutes a day. You forgot about it. But okay, I see you now. And so you say, I feel fine. I don't have anything, because it can take a year or so for people after a diagnosis to accept that I actually have this diagnosis. And then diabetes, with type 2 diabetes, you've likely had it for some years before you got the diagnosis. And so complications can be already present. See, patients come in, they already have the neuropathy, which is the numbness and tingling maybe in the feet, but it can be anywhere. And they're like, I didn't know what it was, or I've lost all this weight so quickly, but I'm looking good, because in this day and age, everybody wants to look and seem a certain way. So you've lost all this weight, and even though you're feeling sleepy, you're feeling tired, you're peeing all the time, but you feel like I've lost this weight, it's all good. But it's really because your body can't, those cells still are craving for energy. The insulin can't get beyond it. So now what's the secondary source for the body? Well, we're going to just burn off some of this fat. We're going to use this fat for energy, but that's a very dangerous thing, because the fatty bodies are still in the bloodstream. That's a lot to say. It's just saying that you're losing that weight is not because it's a healthy thing that you're losing it. You're losing it. You're not trying to lose it. It's because the diabetes is there and it's not being controlled.
Diabetes in control. That's a topic. So in the office, I experienced a scare, and I just want to address scares in general without, putting people's business out. But oftentimes in our daily walk, we see people suffering from low blood sugars or high blood sugars.
Mm-hmm, mm-hmm.
What does that look like, and what would you recommend we do to bring aid to that individual?
So more than likely, the immediate aid is for a patient who has low blood sugar.
Okay.
Now, if you have someone after they eat a high carb meal or they're just not taking their medicine, the blood sugar is going to be really high, so they can be maybe drowsy or maybe tired and sluggish, and likely going to thirsty and going to the bathroom, because the blood sugar, God made our bodies such that it's going to crave what it needs, and so the blood sugar is high because it's in the bloodstream, not in the cell for energy, and stored where it should be stored when we're not eating. So that makes your body say, I got to get rid of some of this sugar, so you got to go to the bathroom a lot. And what happens if you go to the bathroom so much? You're going to be thirsty, so you're dehydrated. So it's a cycle, a never-ending cycle. If you see somebody going to the bathroom a whole bunch and drinking water like they ran a marathon, you're like, okay, is everything okay? What's going on? If you have a family member who's doing that, so you want to know, like, you're showing signs of possible diabetes, or if they have diabetes, have you checked your blood sugar? Have you taken your medicine? And not in a way that's offensive, but just of a concern. A person with low blood sugar, like I always would say, is the most immediate danger, because the brain needs a blood glucose level to be at least at 50 in order to function. But otherwise, the symptoms that you present with a low blood sugar could be sweaty, could be jittery, could be confusion, could look like almost a person who's drunk on the street. There's been cases of patients who have diabetes, who may be on insulin or have type 1 diabetes, whose blood sugars have gotten really low. And they present or appear like somebody who's drunk, like a homeless, or even a person who's just high on drugs on the street. And the police have picked them up and put them in the back of the car. No emergency band saying I have diabetes, and put into a cell and have died.
Oh, no.
And it has happened, and you would think it doesn't happen. It can happen because the presentation can look as such. And over time, some people lose those signs. They really need to have sensors and be mindful over time of, and there's times that you lose levels of sensing that you have a low blood sugar. But in most cases, you will see someone maybe weak, stumbling over words, confusion, sweating is one sign, and just jitters, fine jitters. And you're like, okay, they're saying the same thing over and over again. Are they okay? So let me just see if they aid them, and by giving them something. Now, what I want to make very clear, people say, I just eat something. But when we talked about earlier, simple sugars, like something to bring the blood sugar up really quickly, spike it, and then some that sort of go slower. In the case of a low blood sugar, you want it to spike. So you want something that's going to bring the blood sugar up quickly. So we're thinking honey, we're thinking glucose tabs, but like a person who doesn't have diabetes wouldn't be walking around with glucose tabs, but you might have a Jolly Rancher in your pocketbook. A fruit cup, and make sure it's one that has sugar in it. Regular soda, just 4 ounces. You don't need a 2 liter, just 4 ounces. Or some juice, regular juice. So having those available if it's in your business setting, and you see someone, if you happen to know they have diabetes, because a lot of times people don't share that information. But if you see those type of symptoms, you can just slip them a piece of candy. Are you okay? Because they should always bring something, but they don't always. And sometimes you think you have it, but you don't. The Hershey bars, the Snicker bars, that's not it. You have the fat in them. Fat slows down the metabolism of carbohydrates, so it's not going to spike the blood sugar immediately. So you don't want the Snicker bar. You might want it, but that's not going to bring your blood sugar up immediately. It's going to bring it up, but it's not going to bring it up quick. And when you're low, you want to bring it up quickly.
Okay. And the reverse, the high blood sugar. If someone's forgot to take their medicine.
So you want to get to the medicine and tell them to drink some water and get moving. Try to move and drink the water. If it's really high, they're probably already drinking a lot of water. But what happens is people think they're thirsty. They drinking soda, juice, everything, not knowing your blood sugar is high. The more soda you drink, the higher it's going. So drink some water, and have them drinking water, and have them moving. And if they have their medicine around, please take your medicine, because there's nothing else that's really you're going to be able to do to bring it down. If it gets too high, you can really end up in a coma. Very high blood sugar or very extremely low blood sugar.
Whew, you gave a lot of nuggets.
Yes, but I don't like to lead in fear for anyone, because fear studies have shown it doesn't change for long-term behavior change with fear. I like people to be knowledgeable, understanding what diabetes is. It's not just a touch of sugar. I did a little study on that. Not just a touch of sugar. A touch of diabetes, no, it's not that. You have to take it completely serious when you have it. Doesn't mean the lifestyle modification is something you incorporate into your day-to-day. You don't have to be pointed out. We don't want stigma related to it. But you do have to make lifestyle changes if you want to live, right? And you think, well, I feel fine. I say this, and this is an analogy. Think about a home that has termites, right? So the house and the frame look great. When coming in and out that house, the shingles are looking good, your house still looking good. But them termites is in there just eating up, right? One day you're gonna close that door and that hinge gonna come down and your foot gonna go through the stairs, and you're gonna be like, what in the world is going on with this house? And only find out it's the steroid, not the steroids, the termites. And so that's what I say about diabetes. Diabetes, you can be looking and feeling good because a lot of times you do. I feel fine. I don't have no complications. There ain't nothing wrong with my feet. I'm not like my family. They were on insulin. I'm not on insulin, so my diabetes is not as bad. No, because sometimes we prescribe the insulin earlier. You're on medications to manage your diabetes. Don't think, well, I'm good because I'm not going to lose my leg because I was on insulin. The risk is there. It doesn't have to be. You can be empowered not to progress to complications. Complications are there, and believe me, they build enough dialysis centers for kidneys failing, and we're trying to prevent that. Wow. But it's not for I don't want it to be sad. I want you to know if you have a diagnosis of diabetes, if you have a diagnosis of prediabetes, you can prevent progression of diabetes. If you have diabetes, it can be controlled. It's very important to know that those things can happen and not to throw in the towel. Okay, you can be fatigued because there's a lot, but having your group and having people who, and everybody's not group people. Everybody doesn't like to be managed in groups. We can do groups in my clinic, and we can do one-on-one.
That's great to know.
Yes.
Yeah, I can imagine you probably get more one-on-ones than people in groups.
Because people have been judged. So
yeah,
just know I'm not. That's not how we roll.
That's really good to hear. I really appreciate you stopping by and hanging out with me.
Of course, anytime.
Yes, indeed, and I will include all of Erica's information in the description below this episode. Thank you. You've left me overwhelmed, and I feel empowered.
Good.
But I know that you have something else to say to a newly diagnosed person or a person that's had it for years. Okay. Can you just give something just for somebody to hold on to that may not have had the education
that's fine.
that you are able to provide?
So what I would say, if you are newly diagnosed with diabetes, if you have prediabetes, if you are sitting at home, have diabetes with any level of complication, there's no place that you are right now that there's nothing that you can't do with support to prevent further progression. And wherever you are, not to give up, not to see it as a death sentence, not to see it, my life is over, that you are more than diabetes. You are a whole, unique, wonderful individual who happens to have diabetes that can be managed. And for patients who may have had some of those severe complications of diabetes, like heart attack, amputation, end-stage renal disease, that you have been waiting on a transplant or on dialysis, I'll say this. My father had every complication from diabetes. He had resources, and he still had every complication of diabetes, including he was on dialysis, he was a double amputee, and he had a heart attack. So I'll say this from his standpoint. My father fit his car so he could drive. He was driving until probably a few months before he did pass away. But I'm saying that in the midst of that, the resilience, and I wrote about the resilience he's had with that in spite of those things, because complications can occur. And in his case, he had a lot of them. But what I'll say to you is, with the complications, that in that moment where you are, what can you do to still be empowered for yourself? That is not the end for you if you're even with the amputation. And there's resources available to help you have as much independence as possible in that process. But where are you in your mental health about this? Where are you in the level of stress, the importance of stress? People, we sleep on stress a lot, but stress is killing us. Being Black, period, in America, it's a stressful situation. And so then we don't talk about it because it's become our norm to walk and be in this. I always say being stressful, being the only Black in your division, that was me. Then being the only person of color, when people see you, they're happy, or being the only person of color when they see you, think you're the housekeeper, even though you got the scrubs, even though the doctors that you depended on are dependent on me. Okay. So this is that can be stressful.
Well, I thank you so much for stopping by.
Of course.
Thank you for tuning in to Hidden Parts of the Podcast. Once again, my name is Sean Monet, and our special guest, Erica Hall. Signing out, but we're asking you to please like us, subscribe, and if you enjoyed this episode, leave some comments and then share it. Until next time. Hi, friends. I hope that you've enjoyed this episode. Please remember to subscribe, follow, like, and share. You can also find out more about us, the Hidden Parts Podcast, as well as watch this recording and many others at my website, www.the-inner.me. Bye.